Hi. Right, which vasoactive drug? Thank you very much indeed. These are my disclosures. Okay, and I think fluid is also actually a vasoactive drug, so we mustn't forget fluid as well. But I think we have three types of situation when the cardiac output is too low to support cellular metabolism, when the blood pressure is too low, so we don't have an adequate perfusion pressure to maintain adequate organ perfusion. And I'll also actually include when the blood pressure is too high, and that may compromise blood flow to the tissues as well as cardiac performance, especially in patients with poor cardiac function. I want to stress that hypotension does not necessarily mean shock. So we've got to individualize. And again, this message is coming through from Eric, from Julien, and now from me. A low blood pressure may be perfectly normal for that patient. And so what you have to do for that blood pressure, is that patient compromised? Is there concurrent evidence of organ dysfunction, organ hypoperfusion? So the blood pressure may be 55, 60 MAP or even lower, but the patient may be cerebrating, passing urine. If so, do you need to then drive it higher with nasty poisonous drugs? Again, as Eric said in his talk, and I completely agree, that if somebody is used chronically to having a higher blood pressure, perhaps in those patients, you might need to have a higher goal for them. And that goal, again, the only way you'll know is to find out. So you do a titration. I take what I call a bottom-up approach. What are they like at a MAP of 70 or 75? If that's not good enough, I'll push it to 80. But my message, again, individualize the target to the patient. The other thing I want to stress is even with a normal blood pressure or even a high blood pressure, the organs may still be unhappy. There may still be poor perfusion. So just because the blood pressure is okay doesn't mean that the patient or their organs are not suffering. And classically, patients who are young, healthy, and with good sympathetic tone may be quite badly compromised before their blood pressure drops. So what markers do we look for? Well, we've got the markers of inadequate organ function, their brain, their kidney. They may be getting chest pain, abdominal pain from ischemia, peripheral shutdown, delayed capillary refill, plus or minus a low blood pressure. Biochemically, again, we've got markers. A lactate, again, just because it's high doesn't definitively mean poor perfusion. You know, there are lots of other causes, mitochondrial dysfunction, liver dysfunction, etc. But again, it's worth looking at the lactate and seeing how the patient responds to fluid, to drugs, whatever. Eric talked about central venous saturation. I find that useful as a marker of that sort of supply-demand balance across the body. And you've got markers of organ dysfunction, be it creatinine, BNP, whatever. Okay, now what do we do? They haven't responded to fluid. We've got to do something else, but what do we do? I would argue you need to have the monitoring to then adopt the right drug to that patient. So you need the technology to guide your choice. So I look at the cardiac output, the central venous saturation, and the blood pressure. So if they're adequately fluid resuscitated, do they still have evidence of poor tissue perfusion? If the answer is no, I'm quite happy to observe them. If the answer is yes, do they have a low blood pressure? If the answer is yes, do they have a low cardiac output for that patient at that point in time, suggested by a low venous saturation? If the answer is yes, I'll use an inotrope in that situation to improve the cardiac output and improve the blood pressure. If the answer is they have a low blood pressure, but they don't have a low cardiac output, I'll then go for a vasopressor. So an inotrope when there's a low cardiac output, hypotensive state, a vasopressor when the cardiac output is adequate, but the patient has vascular hyporeactivity. On the other hand, the blood pressure may not be low. Then the important question is the cardiac output too low for that patient and their metabolic requirements at that point in time? An index is a low central venous saturation. If the answer is yes, I'll use a vasodilator. I may add in an inotrope. And if the answer is no, again, consider other causes. It may be a cellular problem, for example, a drug toxicity or whatever. So the problem's more at the cellular mitochondrial level rather than a circulatory problem. And also, I think it's also worth challenging, is that patient chronically hypertensive? Do I need to elevate the blood pressure in that patient? Which pressor? Again, the pharmacology should guide your treatment. So norepinephrine has minimal inotropic effects, metaraminol very little, vasopressin, terlipressin very little, angiotensin very little. Dopamine has a bit. I don't know about France, but certainly in the UK, it's completely out of fashion. Phenylephrine is a fairly pure alpha agonist. So again, you're using drugs which cause vasoconstriction but offer very little in the way of inotropic effect. So which pressors? So again, I generally only use pure vasopressors in patients with a decent cardiac output. Unless the blood pressure is very low and coronary perfusion is compromised, vasopressors will generally reduce cardiac output. So therefore, I avoid them in the low cardiac output states. And these are the patients you predominantly see the fingers, the toes going ischemic, gut ischemia, and so forth. Norepinephrine, if you look at guidelines, that's currently the recommended vasopressin, but catecholamines in general have their problems. The same with vasopressin, terlipressin. They're often effective in septic patients when norepinephrine fails, but in my experience, you're more likely to see this peripheral ischemia if the cardiac output is low. I published this years ago, but again, if you look at the literature, and it's been shown in animal models and in patients, we may see clinically the tachyarrhythmias, the digital ischemia, but there's lots of evidence of harm from catecholamines. They stimulate bacterial growth, they increase virulence, they cause immunosuppression when used for long periods, they affect metabolic efficiency, they're very pro-thrombotic, they decrease bioenergetic efficiency, increase cardiac work, they cause myocardial damage, and these are our first-line recommended drugs. Seems a bit bizarre. And clearly we see these sorts of patients from time to time, and that's clearly not good for the patient, let alone their fingers and toes. So we've got to identify these things early. If we wait until they're necrotic, it's too late. Personally, I think it's important not to warm them directly. Napoleon's surgeon, Larry, taught us this with frostbite, so there shouldn't be direct warming because you'll increase metabolic rate without necessarily improving the blood flow. In these patients, my little secret is to use early on epoprostenol, prostacyclin to try and open up the microcirculation. In terms of inotropes, again, know the pharmacology. All of these are inotropes, but some have dilating properties, sometimes constricting properties. So sometimes you're giving the drug and you may see the blood pressure falling. And you see that, in my experience, particularly with the butamine and the phosphodiesterase inhibitors like enoxamine, milrinone, etc. I put down the bottom, we can talk about this later, but I actually quite like high-dose glucose insulin potassium. So that's a discussion point. So what I choose is epinephrine in the low cardiac output state because it's less vasodilating. What happens, in my experience, is that when you use one of the other drugs, the blood pressure may often drop, and then the patient is given norepinephrine to counter the side effect of the vasodilating inotrope. So it seems a bit paradoxical. You're giving one drug to counter the effects of another. Levosimendan, if you give a loading dose, you'll see hypotension more frequently, but you don't necessarily need to give the loading dose to start the infusion, but it takes longer to start working. But it's, I think, a nice drug. I don't particularly like the phosphodiesterase inhibitors as they have a very long half-life. The others are relatively short. The phosphodiesterase inhibitors, hours, and so if they do cause hypotension, it may be quite prolonged. And as I said, I like high-dose glucose, insulin, potassium, but again, you don't see a quick effect. It takes a number of hours. I'll just mention quickly dilation. I think there is a role for vasodilators, sometimes in combination with an inotrope. So you want to try and improve the peripheral circulation. And again, it can give you clues about what the circulation's doing. If the blood pressure falls with a low dose of nitrate, is it because they're hypovolemic? Is it because there's an obstruction, like a pulmonary embolus or a tamponade or whatever? There are other drugs which I won't go into now for the sake of time. I'll finish there and hand you back to Mark. Let me just...
Thank you, Mervyn.
Pleasure.
What is your feeling, Julien? Do you use norepinephrine, or do you use adrenaline like Mervyn? Do you use levosimendan in septic patients? That's not the way in France, but that can be interesting. So, Julien?
Personally, I never used levosimendan in a septic patient, so I have no experience for this drug. I had a question for Mervyn concerning vasopressor in general and vasopressin in particular. Vasopressin is known and is said to have norepinephrine sparing effect. Mm-hmm. And do you think that what is the worst? Is it worse to have, let's say, 6 milligrams per hour of norepinephrine, or is it worse to have 4 milligrams per hour norepinephrine plus vasopressin? Which is worst?
I don't know. What we tend to do on my unit is compromise. So if the patient gets to about 0.4, 0.5 micrograms per kilo per minute of norepinephrine, that's when we add in either terlipressin or sometimes vasopressin, and you often see the norepinephrine disappearing. The trials, unfortunately, are a bit ambivalent. I think if you look at the trials, many of them haven't measured cardiac output, and I think personally vasopressin, terlipressin can be quite dangerous in low cardiac output states. So again, I think these trials suffer from a lack of decent monitoring. You know, they've just, one size fits all, arbitrarily given the drugs without actually titrating or individualizing to an appropriate patient.
I fully agree. I think that these drugs should be used in patients with your patients, Julien, with hyperoxia, with high cardiac output, and those with SCVO2, which is very high, and there is an increased mortality in these patients, and perhaps in these patients the use of vasopressin, that's the way you think, Mervyn?
Yeah, completely.
Yeah, I agree. Eric?
Yes, I was great talk and pretty interesting to look at it through the various properties, pharmacological properties aspect, and definitely dobutamine. We use it as an inodilator, and that's the test. We introduce it at low doses in the patients who's starting to have compromised microcirculations and compromised peripheral circulations, and we definitely introduce it as an inodilator. And so it's a very interesting way to look at it in your talk. I I was intrigued to see Jake come back, and pretty satisfied to see
Jake
that.
Always come back.
Yeah, it's sometimes looking back is going forwards.
Yeah.
And do you use nitrite? Because we used to use it in some patients with motor, some patients like this with extremity ischemia, and now we don't use it on a routine basis. But that was very interesting. That was a nice paper. That was a research letter in the Lancet. I think you are in, and that was very interesting, perhaps.
Yeah, I think again, I don't use it on every patient, but I think if you pick the right patient, you can make a good pharmacological and biological rationale for it. So I don't think everybody should get it, but if the patient's really shut down, if you can open them up and improve, because what you're seeing in the hands and feet is probably going on to the same extent in the organs we can't see.
Okay, we have two minutes remaining. Do you want to conclude, Eric? Your conclusion?
My conclusion is something we've said a lot, each of us, is after having all these studies that have offered many physiological insights and physiological tools, we always tend to revert back to the mean and want to have a one-size-fits-all approach, which is obviously easier to advocate, but I would definitely advocate for learning the physiology, mastering these tools, and having them in your toolkit to use at each and every patient's bedside in probably a different way for each patient.
Thank you. Julien?
Yes, it's not original, but I would sum up with the same sentences. Have a heavy toolbox, know your tools, and titrate, be humble, and titrate your treatments, because we do not know a priori how the patient will respond to our treatment. So we have to master physiology, pharmacology, to remain humble, and to aim at homeostasis, not over resuscitation, no over oxygenation. Just try to aim for homeostasis in the middle.
And Mervyn?
Yeah, well, I completely endorse Eric and Julien's points. My fear, I think perhaps my generation, we can be accused of crimes against humanity, because I think physiology is dying, and people, I don't know in France, but it worries me that the very essence of intensive care is not
in France. Not in France. That's a Brexit effect.
That's why we had to leave you, to save you from bad thing. But it's a problem in the UK. Medical students aren't taught physiology. Junior doctors don't know physiology or pharmacology or biochemistry, and everything is just following a protocol. And I think, as Eric and Julien said, we've got to be smarter than that.
Yeah. That's the same in France, and I think that's a physiological approach is always the best way to do.
Yeah,
especially for this severe disease. So thank you, to the three of you, and have a good meeting for all these attendees, and stay with us next year. Bye bye.
Bonne nuit.
Thank you very much.
Thank you very much. Have a great weekend.